Today we're going to be talking about a couple of different things. First of all, we're going to describe the evidence-based treatment guidelines for managing ADHD across the lifespan, including pharmacotherapy recommendations and then behavioral therapy recommendations. But let's first start off with a current state. So an estimated 15 million Americans have ADHD. It's the most common mental health disorder of childhood, with 7 to 10% of all children carrying a diagnosis of ADHD. Kentucky actually has the highest rate of ADHD in the nation. 16 to 18% of all children in Kentucky have a diagnosis of ADHD. Currently, boys are more than twice as likely to receive a diagnosis. And, a large part of, as we learn more about ADHD, part of what drives that difference between boys and girls is frankly how we evaluate and assess people with ADHD. Our assessment tools are largely normed on typical presentations in boys. And so the current assessment tools that we have aren't fantastic at capturing the more typical presentation of girls in ADHD, although this is kind of an emerging area of research, is how to better identify these girls. Part of it is that also girls are more likely to have comorbid internalizing disorders and diagnoses, including anxiety, and sometimes that can either mask symptoms of ADHD or mimic symptoms of ADHD. So anxiety might also cause inattention, making it more difficult to accurately diagnose girls. Speaking about diagnosis, so here's, according to the DSM-5, there are two different types of characteristics that we think about when it comes to ADHD: the inattentive characteristics and then the hyperactive impulsive characteristics. I'm not going to read through each of these. You can, look in your own DSM-5 or look at these slides after they're shared for the specific characteristics. But when we're thinking about diagnosis, children must have 6 or more of the 9 characteristics in either the inattentive characteristics or the hyperactive impulsive characteristics. So there needs to be evidence of 6 or more, and adolescents and adults 17 plus must have 5 or more. These characteristics or symptoms must have persisted for at least 6 months. They must cause a negative impact on social and academic / occupational activities or work. There has to be evidence of this is a DSM-5 word. Several characteristics must be evident prior to age 12, and several characteristics must be in 2 or more settings. Now, this is where I don't like the diagnostic criteria that much, because what I define as several might be different than what another clinician defines as several. And so I've seen physicians or advanced practice providers often look for this 6 or more of the 9 characteristics, but only give the diagnosis if there are 6 or more in both settings. And that's not how the DSM-5 has the criteria is written. Several, unless you define several as 6. And so I think it's important to note that you do not need to have the same 6. You don't have to have 6 or more in both settings. There just needs to be overlap. And importantly, it needs to negatively impact their social and academic activities. And so now I'm going to pass it over to Corey and Katy, who are going to talk about pharmacological management of ADHD, and then I'm going to come back in and talk about the behavioral treatment. So do you want me to keep my screen up and then I can just move forward, or Corey and Katy, do you want to use your own screen?
We'll go ahead and share our slides.
Okay, well, I'm going to stop sharing and then send it over to you.
Thank you. You see those slides okay?
Looking good.
All right, perfect. All right, so like Dr. Hopkins said, next we'll be discussing pharmacologic therapy for ADHD. So this is including both stimulants and non-stimulant therapy. So overall, the major goals of therapy for all patients are to reduce and control symptoms, mitigate adverse effects, and then of course, improve daily functioning and quality of life. Medications for treating ADHD can largely be divided into two types. We have our stimulants and non-stimulants. Generally, stimulants are considered first line due to their better efficacy compared to non-stimulants. And stimulants can then be divided into methylphenidate formulations and amphetamine formulations. So evidence suggests that over 90% of patients will respond to one of these stimulants. And then we have our non-stimulants, including mainly alpha-2 agonists, as well as antidepressants. One of the barriers that providers face when treating patients with ADHD is the fact that we have no adult treatment guidelines in the US, but we do have pediatric treatment guidelines from the American Academy of Pediatrics. And as you can see here is a summary of their recommendations. So for preschool age children, parent training and behavior management or evidence-based classroom interventions are first line, but these non-pharm interventions are recommended for all ages as well. Stimulants are first line for elementary and middle school age children, as well as adolescents. With adolescents, it's recommended that they're involved in the decision-making process and are comfortable and agreeable with taking a stimulant. And then the second line recommendations include methylphenidate for preschool age children. And then for all other ages, alternative stimulants should be trialed prior to considering a non-stimulant medication. So focusing in on the stimulants themselves, I wanted to provide a brief overview of the mechanism of action of each. So for methylphenidates, they selectively inhibit presynaptic reuptake of dopamine and norepinephrine. On the other hand, amphetamines decrease presynaptic reuptake of dopamine and norepi and increase the amount of dopamine released from vesicles within the neuron. They also enhance peripheral norepi release and inhibit monoamines. So to sum that all up, therapeutic result for all stimulants are increased intrasynaptic levels of dopamine and norepi in the prefrontal cortex. So here are some general considerations for pediatric versus adult patients. So for pediatric patients, methylphenidates may be preferred first line, and then for adults, amphetamines may be considered first line. But overall, we don't have a lot of guidance on which specific agent to choose within each class. It's based on provider, patient, and insurance preference. So it's important to keep in mind that finding an optimal agent may involve trial and error, and then response to one stimulant may not predict response to another. Some other general information to consider about stimulants. They are controlled substances and have stigma associated with their use, which I'm sure everyone is aware of, which will be discussed more later in the presentation as well. There are more than 30 different formulations of stimulants. ER formulations are generally preferred due to the fact that there is ease of dosing and improved adherence, less peak trough variations, which may improve tolerability and benefits, and then decreased abuse potential. And then not all generic products are AB rated, which in other words, they're not therapeutically equivalent as determined by the FDA. Some key administration and dosing points to consider for patients on stimulant therapy. Peak may be delayed with a high-fat meal. So this is primarily referring to the ER amphetamine formulations. It's an important point for patients to be aware of, especially those in school who may benefit from peak effect earlier in the day. For the transdermal patches, it's important to counsel patients to not apply them to irritated skin, just as you would with any other patch. The duration of action for stimulants is highly dependent on the formulation and delivery system. So keep in mind that the timing of dosing may need to be adjusted to maximize symptom coverage and minimize adverse effects. And then these agents are typically initiated at a recommended starting dose and titrated until the patient notices a positive response. There are some warnings and contraindications to take into consideration for patients, especially depending on their past medical history. So stimulants do carry a boxed warning for high potential for abuse and dependence. And then specifically for amphetamines, misuse may cause sudden cardiac death and cardiovascular events, especially in the setting of pre-existing cardiac conditions. Other adverse effects or warnings include hypertension, tachycardia. They may exacerbate tics, psychosis, or seizures. They may cause peripheral vasculopathy, and it is rare, but they may increase risk of suicidal thoughts and behaviors in certain patients. Looking further into the adverse effects that some patients may experience. So patients can have GI side effects, including stomach upset, decreased appetite, nausea, vomiting, diarrhea, or constipation. They can have CNS side effects, including insomnia, anxiety, emotional lability, nervousness, or jitteriness. For nutritional side effects, we think mainly for our pediatric patients, they may experience growth suppression, as well as weight loss for pediatric or adult patients. From a cardiovascular standpoint, they can increase heart rate and blood pressure, as well as, like I mentioned, other serious cardiac events. And then derm, they can have a pruritus or rash or hyperhidrosis as well. There are some ways to manage many of the adverse effects that patients may experience, either through counseling or medication adjustment. So if the patient is experiencing anorexia or GI distress, it's important to monitor their weight. You can suggest that they eat a high-calorie breakfast or dinner. But as I mentioned previously, meals that are high in fat may delay peak effect for certain stimulants, so that's important to keep in mind as well. For insomnia, you can ensure that the long-acting formulation is not taken near bedtime, or consider switching to an intermediate-acting agent, depending on patient preference, as well as counsel the patient to avoid supplemental doses too late in the day. So we usually recommend that dosing later than 2 or 3 p.m. could interfere with sleep. For irritability or anxiety, consider a dose reduction, as well as counsel the patient to reduce or eliminate caffeinated products. And then you can also transition them to an extended release formulation, which may help to reduce drug peaks and overall feelings of anxiety. That growth suppression that I mentioned in pediatric patients, you can recommend a drug holiday to minimize drug exposure during times that would be least disruptive. For example, over summer break for kids who are in school, and then allow for return to their normal dietary intake during that time period. You can also recommend nutritional supplements. For wearing off effects, you can transition the patient to a long-acting formulation, adjust the long-acting formulation to provide coverage when they need it most, or provide them with a supplemental immediate release medication for coverage. So for example, that would look like taking a supplemental dose at homework time in the afternoon. And then for blood pressure and heart rate, again, you can counsel them to avoid other substances that can increase their blood pressure, such as caffeine. And then if the blood pressure or heart rate changes become intolerable, you can consider changing them to a non-stimulant product. So that brings us to our first audience question. So I'll read the question to you and then give you some time to think about it. So a 20-year-old patient with ADHD presents to your clinic for her annual exam. She's a college student and expresses concern about the wearing off effects that she is noticing with her Adderall immediate release. She takes her medication once daily in the morning and has good results at first, but trouble remaining focused later in the afternoon to complete her homework. So which of the following changes can you recommend to help with this concern? And there are more than one right answer. You can either recommend a drug holiday, switch to a non-stimulant medication, switch to a long-acting formulation, or switch to twice daily dosing. All right, so we got our results here, and it looks like everyone either chose C or D, which are both the correct answers. So for A, we know that's not the right answer because that's recommended for growth suppression in our pediatric patients. And then we don't want to switch her to a non-stimulant medication because it seems like she is having positive effects. So we can either switch to a long-acting formulation to provide her coverage later in the day, or give her a supplemental dose, or switch her to twice daily dosing as well. All right, so not only do we have to consider adverse effects, but also potential drug interactions in these patients. So of course, stimulants can interact with other CNS stimulants and have an additive effect by increasing heart rate or blood pressure, as well as along the same line, stimulants may diminish blood pressure lowering effect of antihypertensive medications. Some other things, methylphenidates may increase tricyclic antidepressant levels. Opioids can increase amphetamine levels. And then there is a serious interaction in between MAOIs and stimulants with the risk of hypertensive crisis. So a 14-day washout period is recommended between those two agents. We don't see MAOIs much in practice anymore, but they are listed there for your reference. For safety and monitoring of these medications, at baseline, it's recommended to screen for cardiac disease, but important to keep in mind that routine EKG is not recommended for young patients without a cardiovascular history. And then, of course, some of the other things that we have talked about, such as blood pressure, heart rate, weight, and substance use history. For follow-up monitoring, we can keep an eye on some of the adverse effects that we had mentioned previously. So anxiety, insomnia, agitation, dysphoria, any kind of sexual dysfunction, as well as blood pressure, heart rate, height, and weight. And then peripheral vasculopathy. So if we're concerned about that, we can look out for things like pain, numbness, and weakness in the patient's legs and feet. If they have any skin discoloration or slow wound healing. And then for frequency of follow-up monitoring, like I said, we don't necessarily have guidelines in the United States to recommend frequency, but the European guidelines do recommend at least blood pressure, heart rate, and weight every 6 months for these patients who are on stimulants. So the following two slides are mostly for your reference to see the available methylphenidate and amphetamine products and show their formulations, duration of action, and dosing and administration. So here we're starting with the methylphenidate products. The short-acting agents have a duration of approximately 3 to 5 hours and are generally dosed more than once daily. The long-acting agents have a duration of 8 to 12 hours and are generally dosed once daily. And then we have the transdermal formulation, which has a duration of 10 to 12 hours. And the important administration note that it should be applied 2 hours before the desired effect and removed after 9 hours. And then next we have the amphetamine products. So very similarly, the short-acting agents have a duration of 4 to 6 hours. And again, generally dosed once daily. For amphetamines, there is an agent considered more of an intermediate acting, which has a duration of 6 to 8 hours. But in general, the long-acting agents have a duration of about 8 to 12 hours, some up to 16 hours, and are dosed once daily. And then similarly, we have the transdermal formulation with a duration of 12 hours and with the same administration note as the methylphenidate patch. So that is our overview of stimulants. Next, I'm going to pass it off to Katie to talk about non-stimulant medications.
Yeah, so like Corey said, now we're going to review and talk about our non-stimulant options for ADHD. Our non-stimulant medications include atomoxetine, viloxazine, vompacine, and clonidine. Additionally, tricyclic antidepressants and bupropion can be used off-label for ADHD. Non-stimulant medications are not first-line treatment, as Corey had mentioned. Adequate trials of both methylphenidate and amphetamine classes are recommended before trialing non-stimulants. Our non-stimulants generally should be reserved as adjunct treatment or for those who are unable to tolerate or are contraindicated to receive a stimulant medications. Studies have demonstrated the superiority of stimulants to non-stimulant medications. One systematic review of 133 double-blind randomized controlled trials assessed the efficacy and tolerability of oral medications for ADHD, and they found that amphetamines were significantly superior to atomoxetine in both children and adults. Getting into the pharmacology of these specific agents, atomoxetine and viloxazine are both selective norepinephrine reuptake inhibitors. Both have daily dosing, although atomoxetine can be divided into twice daily doses if needed. Guanfazine and clonidine are both extended release formulations and are central alpha-2A adrenergic receptor agonists. Both should be started at a low dose and increased weekly based on effect and tolerability. And all four of these non-stimulant options are indicated for patients 6 years and older. Just looking a little closer into that mechanism of action, atomoxetine and viloxazine work by inhibiting the presynaptic norepinephrine transporter and prevent the reuptake of norepinephrine throughout the brain, and this results in an increased synaptic level of norepinephrine. Clonidine and guanfazine are both alpha-2 adrenergic agonist drugs. Guanfazine is selective specifically for the alpha-2A receptor, and it inhibits norepinephrine transporter and increases the synaptic levels of norepinephrine. Clonidine does act on multiple alpha-2 adrenergic subtypes, both A, B, and C, and these additional sites of action result in the stimulation of more of those postsynaptic alpha-2 adrenergic receptors. Non-stimulants do have some adverse effects that can be seen across pretty much the entire class of medication. These include GI distress, such as decreased appetite, nausea, vomiting, constipation, and diarrhea. Cardiovascular-wise, we can see increases in blood pressure and heart rate and orthostasis. Central nervous system effects can include insomnia, irritability, anxiety, drowsiness, and they also have an increased risk for suicidal ideations and tendencies. And then these can also have the adverse effect of excessive sweating and dry mouth as well. Management of these side effects are going to be similar to kind of what Corey has already discussed for our stimulant medications. Looking a little bit more into some of these drug characteristics, atomoxetine and viloxazine are both contraindicated with the use of MAOIs. Atomoxetine does have the additional contraindication for use with severe cardiovascular disease, narrow angle glaucoma, and pheochromocytoma. Atomoxetine also carries a box warning for risk of suicidal ideation and has increased risk for serious cardiac events and arrhythmias. Both atomoxetine and viloxazine have the potential for sexual dysfunction and hepatotoxicity. Monitoring for both of these drugs should include liver function tests, EKGs in patients with a cardiac history, also monitoring blood pressure, heart rate, and for behavioral changes. Guanfazine and clonidine put patients at an increased risk for hypotension and syncope, so we should be monitoring blood pressure, heart rate, and then also behavioral changes as well. Some other non-stimulant medication options include the off-label use of TCAs and bupropion. Patients with comorbid mental health conditions may be the place in therapy for these off-label uses for ADHD to kind of help alleviate any depression and or anxiety symptoms that they may be having simultaneously with their ADHD. Because data for their use in ADHD is pretty limited, they're typically reserved as our last line treatment option. ADHD does commonly present along other comorbid mental health conditions. In 2016, there was a survey that was done that found that 60% of children with ADHD had at least one other mental health condition, such as anxiety, depression, behavior or conduct problems, substance use disorder, or autism spectrum disorder. In adults, depression and anxiety are often comorbid with ADHD and can actually be caused or exacerbated by longstanding untreated ADHD. And in these situations, treatment of ADHD alone may provide relief of these depression and anxiety symptoms. Some other conditions that may present alongside ADHD with ADHD symptoms include oppositional defiant disorder and language and learning disabilities. Treatment of these disorders can help alleviate those ADHD symptoms. Additionally, there are some conditions that can present as ADHD, but are relieved by just treating the primary condition alone. This can include sleep disorders, absent seizures, and hyperthyroidism. Kind of the last thing I wanted to talk about and acknowledge is the stigma that surrounds stimulant use and prescribing. Many fear the abuse potential of stimulant therapy and their association with ADHD. However, the association between ADHD and substance use disorders remains pretty controversial, and we do have some studies out that have aimed to disprove this association and decrease stigma. So studies have shown that an ADHD diagnosis alone increases a patient's risk of substance abuse. However, the treatment of ADHD with stimulants does not. There is an analysis done of 37 studies that included over 10,000 children, and they found that children with ADHD were 2 to 3 times more likely to develop a substance use disorder. And then subsequent analysis, follow up on 15 of those studies with over 2,500 children with ADHD, found that those that were treated with a stimulant medication had no greater risk of abusing alcohol, marijuana, nicotine, or cocaine later in life. And there's another multi-site study that was done in the US and Canada on the association between stimulant treatment and substance use through adolescence and into early adulthood. This included 579 children who were age 7 to 9 years old with a diagnosis of ADHD. They performed repeat assessment until these patients were a mean age of 25 years old. And the study found that there was no evidence of stimulant treatment was associated with increased or decreased risk of later abuse of alcohol, marijuana, cigarettes, or other substances. If stimulant abuse or diversion remains a concern, we could consider specific stimulant formulations. One example being using a prodrug such as lisdexamfetamine, which is going to be therapeutically inactive until it's metabolized. Alternatively, we can opt for a tamper-resistant stimulant, such as a long-acting methylphenidate, that's going to have more of a controlled release system. And that will bring us to our second and last question. So we have a 12-year-old patient who's newly diagnosed with ADHD. He presents to your practice with their parent. When discussing treatment, the parent expresses concern about stimulant medications because they've heard it is addictive and can be abused. Which of the following counseling points can you provide to help decrease this concern? This again is another select all that apply. So we have A, stimulant medications are the first-line treatment for ADHD recommended by the pediatric guidelines. B, non-stimulant medications are proven to be more effective than stimulant medications. C, studies have shown there is no greater risk of substance abuse in children with ADHD who are treated with stimulants. And D, certain formulations of stimulant medications can be used to help mitigate concerns for abuse and diversion. So A, C, and D were our correct answers. So the only incorrect one was B, and it doesn't look like anyone selected B. That one is just going to be incorrect because we do have those studies that show the superiority of stimulants to our non-stimulant treatments of ADHD. Now I will go ahead and pass it back to Dr. Hopkins.
All right. Whoops. Let me go back to sharing my screen. Okay. So let's talk a little bit about how to improve adherence of treatment and then also behavioral modification. So we know that adhering to treatment for ADHD really relies and can be improved when we can provide really high quality parent and patient psychoeducation around ADHD medications using the information that Corey and Katy provided earlier. the rationale for medication treatment, why it's considered to be the front line of treatment, and then the procedures for establishing an effective medication and dose. So oftentimes, it's helpful to discuss with a patient or a parent to expect that most physicians and advanced practice providers start low and go slow in terms of finding the right dose. A metaphor that I often hear used is it's like, although this is a metaphor that's going to age me, it's like tuning a radio on the FM or AM radio dial until you get a clear sound. So helping families understand what to expect, that oftentimes where you start on a medication may not be where you end up. And it's about finding out what works best with each patient. Along with that, we find that combining medication with brief behavioral interventions for both children and adults can help considerably when it comes to treatment adherence. The goals of those interventions include reducing parent-child conflict, so you see better outcomes in symptom management. And so that's certainly true when it comes to treating kids and adolescents. And then with folks across the lifespan, brief behavioral interventions that focus on increasing structure and organization. The evidence-based behavioral interventions based on age level. For the pre-K, so children under the age of 4 to 6, the front line of treatment is actually parent training and behavior management. And so that includes evidence-based treatment models such as Triple P, Incredible Years, parent-child interaction therapy. So medication for this age group is not recommended as the front line, although there are times where it's appropriate to consider medications for kids in this age group, particularly if their symptoms are posing a safety issue, causing significant disruptions in sleep, or if they are unable to remain in a school setting because of their disrupted behaviors. That's when following up with a psychiatric provider would be indicated. For elementary age children, ages 6 to 12, the evidence-based behavior therapy continues to be parent training and behavior management, as well as educational interventions. So this is something that I see happen quite a bit in the patients that I treat as a psychologist in primary care, is that patients have been diagnosed with ADHD, but perhaps were told by their primary care provider or the person that confirmed the diagnosis that they should, in addition to medication, also get behavior therapy, and that's all they say. And so understandably, parents might look for individual therapy for their kids, only to find that it really doesn't help or address the symptoms. And that's because we know that with this age group, individual directed therapy interventions really don't work with this age for kids that have ADHD. So the way that I phrase it when I'm working with parents and providing them this parent training is, I'm going to teach them what a therapist might do in their office to help manage disruptive behaviors, dysregulated moods. Because for kids who have executive functioning deficits, they really need in the moment coaching about how to problem solve, how to complete tasks, how to reduce their frustrations. And if you're working with a therapist once a week or once every other week, you don't have the benefit of that in the moment intervention. Similarly, we know that treating ADHD requires educational interventions to make sure that their symptoms are not getting in the way of their learning. And so that might come in the form of what's called a 504 plan or an IEP. Oftentimes, these plans require documentation from a medical provider or mental health professional documenting the diagnosis and making those recommendations. So that's where prescribers and providers can really help children gain access to these educational interventions, is by recommending them. For adolescents, that's when we do see some efficacy with cognitive behavioral therapy interventions directed at the teenager themselves to help them improve their ability to complete tasks, improve their ability to manage their emotions, in addition to organizational interventions, and then again, educational interventions similar to those we recommend for elementary age kids. In adults, cognitive behavioral therapy has been shown to be effective in helping folks with ADHD navigate the life challenges that they experience having the disorder, as well as organizational interventions. I will also say that adults can receive accommodations in the workplace and in college settings if they have a documentation of ADHD. Many adults in my experience prefer not to share that information with their employer, but just like any chronic health condition or disability, they are entitled and protected under the Americans with Disabilities Act to receive accommodations in the workplace if they have ADHD. So those are the primary, I'm just going to stop sharing. Those are the behavioral recommendations. And I think it's important to note that these are in conjunction with medication management. So we just know that if you pursue behavioral strategies alone, that they are less effective than medication and behavioral strategies. It's important that when you're working with patients that have ADHD or that have a child with ADHD, that you educate them on why we recommend both, and that a part of your role as a prescriber may be helping to address some of their hesitancy around medications. And I think Corey and Katy did a good job of covering some of the concerns, whether that be this worry that there might be an increased risk of substance abuse or worry about adverse effects. And so you can go back to their recommendations about how to navigate those questions. Speaking of questions, if anyone has questions for me or Corey or Katy, we're happy to take those now.
Thank you so much for your presentation today, Dr. Hopkins and Dr. Stevens and Miller. This was really exciting and really timely. I think it's a challenge that many parents and kids are facing. So I'm really grateful for you all being here today.
Thank you. Me too. I'm always happy to talk about it.
Yeah. Any questions from our participants today? We've got a lot of you on. Dr. Hopkins, I wonder if you can share in what ways it's most helpful when the non-medication-based team interacts with the medication-based team and what that facilitated integrated collaboration might look like.
Sure. So I have the very lucky, fortune of working within a primary care clinic. And so I get to literally work alongside these pediatricians and advanced practice providers who are managing medically kids with ADHD. One of the things that's really lovely about that collaboration is that as a behavioral health provider, I may actually see the family more frequently than a prescriber who may only see them every 3 months for a med check. And so during my visits, I can check in and ask questions related to side effects and whether or not medication is working. I can help do ongoing assessment of symptoms with medication and see if that is helping. And then also really, I think that because of how my appointments are structured, I oftentimes have more time than a provider might have to explore areas of concern related to medication. Certainly, I'm going to defer to the prescriber if I really feel like it's a medication specific question, but even those discussions around hesitancy around starting a stimulant, I can spend a lot of time exploring what their worries are, share the research as I know it, and as Katy and Corey presented today. And so it really allows me good collaboration with those providers and with families to make sure that kids are getting optimal care.
Dr. Stevens and Dr. Miller, you all gave so many great pearls on prescribing both scheduled stimulants as well as non-scheduled medications. What are ways that that individuals prescribing who may not be comfortable with prescribing might collaborate with pharmacy when considering the nuance of the patient they're caring for and how they might approach that clinical situation?
Yeah, that's a great question. And unfortunately, we don't have pharmacists in all of our, primary care clinics. But I think the pharmacists that we do have available are always happy to answer any of these questions. So I think just from that standpoint, if there are questions about adverse effects or how to manage those adverse effects, which I feel like for a lot of these patients are the biggest worry, always reach out to our pharmacist and we would be happy to answer or have those conversations with the patients as well.
Yeah.
I wanted to just add a piece, if I might, about the value of managing adult patients with ADHD in primary care. So if you'll remember from one of our earlier slides, approximately 16 to 18% of Kentucky's children have an ADHD diagnosis. That diagnosis doesn't magically disappear the day they turn 18 and move to an adult primary care provider. But unfortunately, for a lot of patients across the state, their care disappears, meaning it is significantly harder to find an adult primary care provider who feels comfortable managing the same medications that were prescribed in pediatrics. And for many of these patients, they've been long established on medication. They found medication that works. So this is just my, advocacy for this population. Certainly, we know that adults' brain continues to grow until they're about 25 or so, and their executive functioning can improve, and environmental changes can also reduce the impact of negative symptoms, even if they're not on medication. But for many adults, they still do need medication, and that is a huge missing link in our community and within our system. And so I hope that those of you who are participating today, if you do treat adults, that perhaps today's presentation helped increase your comfortability with managing these patients, because this is a huge need. Just even for my patients that are aging out, where I'm trying to find a primary care provider within the Norton system that can continue to manage them. Oftentimes they're referred to psychiatric care or specialty psychiatry, and there are just fewer psychiatric providers in our community than there are primary care providers. So hopefully the information shared today helps increase everyone's confidence level in managing these patients that really have that need.
Yeah. There's a question in the chat, and Dr. Hopkins, I'm happy to have you answer, or if you want me to help, just let me know. What is the standard of care in making the diagnosis of ADD, ADHD in adults?
There is not one. How's
So
that for an answer?
Use the diagnostic criteria. So
you can look at the diagnostic criteria in the sense of if there's evidence of 5 or more of the symptoms, with several being present before the age of 12. But what's really hard is that for some folks with ADHD, they're not great historians. So they can't remember exactly when they started having symptoms. They don't have necessarily the benefit of a parent or a partner that can collaborate in providing additional history of symptoms. Sometimes people with ADHD do not have a lot of insight into how their symptoms impact them, but a partner might observe more symptoms than they perceive that they have them. So when you're evaluating and diagnosing an adult, having an additional person, like, that they're in relationship with, whether it be a partner, a close friend, a family member, accompanying them so that together they can give those. But certainly you can follow the diagnostic criteria, and it can be as simple as that. When I say we don't have a standard of care in terms of assessment, what I mean by that is we have assessment tools that are normed for children and adolescents, and we don't have those same great tools for adults that are consistently shown to be good at capturing those symptoms in adulthood. So this was largely thought of as a disorder of child development. And it is a developmental disorder, but we also know that there are plenty of adults who never had access to assessment or evaluation that might be seeking that diagnosis now. And so having better assessment tools would help us better capture those. But in the meantime, we can rely on the DSM-5 to guide us.
Well, I think your point is well taken. A person who has trouble following through on tasks, or is easily distracted, or has trouble finishing things out, may not observe that pattern of behavior in themselves. And so collateral, we rely heavily on collateral in pediatrics because we have parents readily available, but collateral can be equally important in the adult setting. Sometimes more important, to have that brave person with the individual in the waiting room being like, but you don't follow through on anything we talk about at home, right? So it's important to have that.
Yes, yeah.
I put the DSM in the chat just so you can see the criteria, but to Dr. Hopkins' point, following the criteria to the T is not necessarily the standard either.
It's not. And, as I said, this is also criteria that has evolved over time. And there's a lot of things about ADHD that are not included in this criteria, like emotion dysregulation, which is a common experience of people with ADHD. There's nothing about emotions in that criteria. And so, my hope is that as we understand and research ADHD more, we'll have a better assessment guide when it comes to those more challenging evaluations, whether it be an adult or a girl who may have who may look like she's paying attention, because that's the other thing that I think is really important. While collateral information is really necessary, particularly for children and adolescents, a lot of girls particularly are socialized to look like they're paying attention. So if we are relying on observational data and a child looks like they're paying attention, we don't have a great way of identifying what their executive dysfunction really is, based on just observation of their behavior alone. And I've worked with lots of girls who describe feeling overwhelmed and anxious about missing information in school, not paying attention, not getting a good grade, as they've been socialized to be concerned about. And so their teachers aren't picking up on the fact that they are struggling.
There's another question. How common is it to diagnose ADHD or ADD in an adult who never had issues in childhood or adolescence?
Well, I think that that's a tricky question. I think technically, based on the criteria, it's fairly uncommon to diagnose an adult who has no history of problems as a child or an adolescent. I mean, that's essential to the diagnostic criteria as it's written right now, is that there has to be evidence of dysfunction prior to the age of 12. I think that it takes a savvy clinician to really, person may not remember their childhood much or remember much of an issue, or it may have a complex social history. And so it may be difficult to determine, but it's pretty unusual for someone to be diagnosed when there's like zero history of dysfunction. That doesn't mean that it's not an accurate diagnosis, but there's also lots of other reasons why there may be a sudden onset of executive dysfunction. Another mental health issue, other related environmental things that happen. Now, certainly there could be a traumatic brain injury or exposure to certain toxins in your environment that could basically cause symptoms that mirror ADHD. You know, there are arguments that even though ADHD is technically a developmental disorder, thus it must be present in the developmental stage, if the symptoms are present because of something that happened in adulthood, could we not still treat it the way as we treat the developmental version of ADHD? And there is evidence that executive dysfunction, regardless of whether it's been a lifelong executive dysfunction or current, does benefit from stimulant medication and the behavior strategies that I discussed.
Thank you all so much for being here. We're right about time. I just want to remind everyone that you're going to receive a evaluation for credit. I believe there's a link in the chat. When you exit the webinar, you're going to see the link to SurveyMonkey. Click continue, the continue button for evaluation and credit. I would really love for you all to join us next time in our pharmacology series on Thursday, October the 24th, where we're going to discuss URI management in the pediatric setting. Dr. Hopkins, Dr. Stevens, Dr. Miller, thank you all so much for sharing your time and expertise with us today. And I hope everyone has a great day. Thank you all for being here and participating.
Thank you.